According to a recent report funded by the Department of Health, people with a learning disability die younger than those without a learning disability and are 58 times more likely to die before the age of 50. Men with learning disabilities die on average 13 years sooner than men without, and women 20 years sooner. Of the deaths of the learning disabled investigated, 42% were assessed as premature, and the main reasons given were a delay in diagnosis, investigation or specialist referral, and problems with their treatment. People with a learning disability have more medical problems than people without. But despite previous investigations and reports, many healthcare professionals are not aware of or do not make any reasonable adjustments to meet their needs.
My Worcestershire Health Plan was developed in response to the self-assessment framework for 2012, and the self-assessment framework, often referred to as the SAF, is the opportunity for people across the country to have their say on how they feel health services are responding to the needs of people with a learning disability. As part of the process, the Joint Commissioning Unit talked to people with a learning disability, family carers, support providers and partners across health. A group of representatives then sat on the health subgroup of the Partnership Board and worked together to pull the information into a 3-year plan, My Worcestershire Health Plan.
The 5 big health aims are to make sure people with a learning disability have a good experience of health services and good health outcomes.
The plan gives us a vision and principles of what people with a learning disability expect from all of their health services in Worcestershire.
We want to tell healthcare professionals what they can do to give better care to people with a learning disability. We want to tell them how we think they could make it better and what good things are being done.
Big health aim number 1, my GP practice. I should have my health care needs met through my GP practice whenever possible with the right support and adjustments.
Patients with learning disabilities often have very complex health needs, and there's good evidence that they are more likely to be admitted to hospital with acute illness and die before the age of 50.
In the annual health check, I didn't have a blood test, and didn't have a blood test, nor a urine sample, and they didn't do nothing for me in that situation. Should have done it all. Should have done a blood test and everything, and a water test, but he didn't.
I think annual health checks are important to, if you've got something wrong with you, you can get treated for it.
Then they found out when I was in the ward that I had diabetes. They could have stopped me from going into hospital and stuff like that.
My GP hasn't been largely involved, but I don't know whether that's because it's not his field, you know, he's not his speciality sort of thing. I think GPs know a little about everything. He needs the specialist services, he needs complex, you know, people that have got complex needs do need somebody, a team around them that know what they're talking about.
And often patients with learning disabilities do have severe communication difficulties and are unable to communicate just how ill they are. And it raises awareness for both patients and carers about health issues and what sort of things to look for.
Communicate to the doctor quite well and ask her loads of questions now because I got used to her and she's quite nice. But I didn't before, I wouldn't really talk, but now I'm quite good at doing that. We did look up when I got to go again and it is this month. And then I had a letter about I got to have my eyes tested as well. So we can look back at some of those appointments and then we know then to go. Big health aims number 2. My community service. I should be able to access health services in my community when I need them with the right support and adjustments.
The Community Learning Disability team support providers who contact them to say that people are in crisis or that they themselves need more support to manage people's behaviour or people who are having a particularly difficult time.
I always get a bit nervous going to somewhere new and you don't know which way to go.
The team also have a range of support staff that will accompany people with a learning disability to access mainstream provision. This could be attending hospital appointments, preparing for surgery, assisting with understanding, advice and guidance received by medical practitioners.
I remember how I went on to have an X-ray on my tummy and then put me with a board at the bottom of me, but it wasn't very comfortable. And that helped me to get comfortable.
I had a letter come through saying that I had to go and see an ophthalmologist at Worcestershire Royal on a Saturday, but the letter didn't explain why I had to go or what was going to go on. I was getting more and more anxious about it. She had written a letter to my doctor, but we couldn't understand her writing. She shoved it in an envelope and sealed it before I could read it. I didn't know what she'd put in it. So it was all like, oh, what's going on? Big health aim number 3, my hospital visit. I should be able to have the support and adjustments that I need when I go to the hospital.
We're just about to launch the blue boxes on each of the wards. It's an information box for staff on the wards to know who the acute liaison nurses are, the pledge, the charter, the referral forms, the questionnaires.
We're extremely fortunate to have a very proactive learning disabilities team who work in very strong partnership with the Acute Trust to improve our patient experience for patients with learning disabilities. In terms of benefits to patients, we have lots of alert systems which notify the team that a patient is due to come into hospital for outpatients appointments, for pre-operative assessments. Often the team will do home visits to support the patients, and also they'll visit them in the clinics to support them in terms of preparing them for what to expect.
I was a little baby and I was in hospital all the time. The doctors keep coming into me to see if I was all right, and lots of needles and things like that.
I did actually approach the community nurse for learning disability team, who was our saving grace really, and we'd had multiple call-outs from the GP. But the team were able to get us moving, get us into hospital. It was extremely difficult because when you're put onto a medical assessment unit, there's probably quite a few others there, and usually they're all male
and I'm female, and that presents a problem.
So when we do have a patient on the inpatient wards, the liaison team will work with us to deliver training to staff on the ward regarding that particular patient's requirements. They'll do what they call the 5 key messages in 5 minutes. And it's a quick and easy way to make sure we really focus on the unique, reasonable adjustments that patients require whilst they're in hospital.
I do like to stay with Martin. He needs a lot of reassurance. They can accommodate parents, but it is very difficult on the medical assessment unit.
But in terms of representing the clients whilst they're in hospital, if we do see any disservice or etc., which generally we don't, but obviously there are occasions when that does happen, then we would advocate very strongly and sometimes maybe not that popular.
Big Alf aims number 4, complex need. If I have complex need, I should have the right support at the right time in the right place.
We value the right of people with complex needs to live in the community. Therefore, we commission individual packages of care, offering people the opportunity to have personal budgets and direct payments so they can take as much control over their life as possible. In addition, we are commissioning new services such as day opportunities and supported living so that people with complex needs can live as active a life as possible in the community.
If we look at historically not an easy option as such, but one of the options that was available quite often to when somebody was breaking down in terms of their behaviour or their complex issues was that hospital stay would be able to look at medication, controlling somebody in terms of a chemical restraint for a time being to enable that person to then look at how then you could transition them back into the community. I think there's a number of things that came up in terms of post-Winterbourne. I think one of the things mainly was around communication, listening to people, certainly carers and family involved. I think that seems to be, certainly from if we look at the situation with Jake, clearly you as an authority have listened very much to what the family wanted and you've supported them through that process by looking at different providers, looking at professionals involved, making sure they had the right support at home. So I think what this is, for hopefully shown that we can provide that kind of level of support within a person's own environment and still make it cost effective.
We monitor all hospital placements very closely. That's both the social worker for the person with complex needs, but also through our specialist commissioning team who visit hospitals to ensure that standards are being met and that quality is being provided.
We're speaking to staff, we're observing interactions between service users and staff teams, and we'll do as many visits as we want to, really, to make sure that we've got a really good understanding of that service user, and if there's any question that somebody wasn't being treated with dignity and respect, then we would be addressing that with that provider and getting the support that they might need to change their practice.
This ensures that there is early planning for discharge prior before somebody's admitted.
I think it's very, very important that they spend the least amount of time on 2 fronts. Firstly, it will reflect to us as a service that we are delivering in terms of the outcomes. Secondly, the patient does not become institutionalized. The longer they live in an area like this, it makes them more reliant on staff.
In our opinion, we feel that a lot of our service users have been in services for a long time anyway. We've not really had many patients that have not been in services for less than 12 months. And who wants to be in hospital? People want to be home. And our aim is, okay, you've been in hospital a long time. Where is it? Where has it gone wrong? Where can we put it right?
We would worry if someone comes to us because we've got a set time where we would like to deliver our outcomes and be able to enable the person to live in the community successfully.
If you spend a lot of time in hospital, all you end up is being institutionalised, you lose your skills, living a life. That's our main aim, is for them to live a life, not an hospital.
Big health aim number 5, family carers. If I have a family carer, they should get the right support and information to help me with my health and their own.
Even now with annual health checks and doctors, GPs are becoming perhaps a bit more experienced of dealing with a whole raft of people with a whole range of different kinds of learning disabilities and quite complex needs. Things still can get missed. And I think it's family carers very often are the ones who can say, well, hold on a minute, we haven't checked this, we haven't checked that. And prevention is better than treatment. It's much better for the person themselves. It's also much better for the health economy. Sometimes hospitals don't understand what reasonable adjustments are needed. The family carer can often provide that information, and it can be something quite cheap.
We try to have all our carers flagged on our computer system so that we're aware that they act as carers, and obviously they will have their own needs.
Family carers will have known that person from birth. They will have had lifelong experience with that person. And I think more and more now the professionals agree that family carers do hold a huge store of expertise.
We like carers to come with the learning disability patients to their health checks so that we can discuss any needs that the carer might have in addition to the learning disability patient.
There's a lot of people who can't speak up for themselves. Even those who can speak for themselves with learning disabilities need support, and sometimes that could be the family carer. Any of the responses to the Francis book, because if you do that, you actually then create access for an awful lot of other people too. You know, people for whom English isn't the first language. Involving family carers properly as true partners is a win-win situation for everybody.
See the person, not the learning disability. We're all in this together, so let's see what we can all do to improve services for people with a learning disability.